Good morning. I'd like to thank Bob and Rick for inviting me to this very enjoyable meeting and giving me the opportunity to talk about a subject that I've been involved in for some time now. So the question that's been posed is, what would disease-free status look like in multiple sclerosis, and what is the evidence that we can achieve it? Cutting to the chase, whenever I give a meeting on disease activity-free status, I get criticized, mainly by the doubters or cynics in the audience, that all we're trying to do is allow MRI, a new technology, through the back door. My argument to them, when you look at the front door, or the clinical door, is a little bit antiquated and seriously in need of update. It's, as you're aware, defining what relapses are, putting a severity to a relapse, and defining disease progression using the EDSS is not a simple task. And as you all know, the literature and from personal experience, it's a very unreliable state of affairs. Whereas MRI does allow us some objective measures or metrics that are easier to measure and potentially can be automated. Well, I'm going to give you an example of how we have already incorporated MRI into our practice, and I'm not for diagnostic reasons, and I'm unsure why people are resistant to allow us to use MRI for monitoring. So we need to go back and define what a disease is. And if you're into the philosophy of medicine, I suggest you read Wittgenstein, and we use his philosophical arguments to classify most things, including diseases. And multiple sclerosis is no exception. So we can either define it by pathology on biopsy, using a well-rehearsed biological definition, or if we knew the cause, we could define it by a monothetic criteria using a theoretical definition. Unfortunately, we do not know what causes multiple sclerosis, so we have to rely on the pre-theoretical definition of the disease, in other words, our diagnostic criteria. Now, the pre-theoretical definition of multiple sclerosis is based on demonstrating a disease that involves one or more white matter structures separated in time, and we have to show there's no other etiology. And we've had criteria now, or formal criteria, since the Schumacher ones that came out in '65. These were put together mainly to recruit patients with multiple sclerosis for clinical trials, and used clinical criteria only. And we've had multiple renditions of this as we've acquired new technologies. For example, the POSA criteria incorporated neurophysiology and laboratory measures, that's spinal fluid analysis, and then the McDonald criteria incorporated MRI, and the subsequent ones have been improvements mainly on the MRI criteria. So we are evolving our definition of this disease by refining the criteria over time. Now, for a set of diagnostic criteria to be evaluated, we have to show how sensitive and specific they are. And most people in the field will say that criteria have to have a sensitivity and specificity of greater than 80%. Now, how good are the criteria we use for diagnosing multiple sclerosis? Well, they're not necessarily very good. Actually, they've never formally been studied like they have in other fields, but this is the largest and probably the best paper that have tried to assess the sensitivity. If you'd previously lived in Denmark and died, you almost all had a post-mortem. You had to opt out of a post-mortem. And in this study of over 5,000 post-mortems, of which 518 people with multiple sclerosis died, at post-mortem the diagnosis was correct in 94% of the time. In other words, in 6% of people dying with a diagnosis of multiple sclerosis, another diagnosis was made. Now, for those of you in the audience, you may think this is a scary figure. Well, it's a lot better than our colleagues in other diseases do. For example, in Alzheimer's and Parkinson's disease, the false positive rate, in other words, misdiagnosis rate, is probably in the order of 20 to 25%. And I think this sensitivity is correct because when they looked at 33 patients that had been diagnosed under POSO as having probable MS, so this is not clinically definite MS, at post-mortem only 66% had confirmation and the other 33% had other diagnoses. So the criteria look very sensitive. Now, this study was done in the POSO era, so the POSO criteria era, and since then we've had the McDonald criteria, and I would be very interested to know if the McDonald criteria performed as well as this. Some people would say they would perform better than this because we now have MRI. Unfortunately, I have a suspicion that may not be correct. The reason for that is diagnosing multiple sclerosis earlier may make us make misdiagnoses and include people with other diseases as having MS. So these criteria would have to be evaluated fresh. What about the specificity? And this is the scary figure. This is well below 80%. In other words, if you just took a group of people dying and you found who had MS on post-mortem, 25% of the cases that were diagnosed as having multiple sclerosis on post-mortem were never diagnosed in life. In other words, they either had no symptoms, were asymptomatic, or had very benign disease that wasn't ascribed to multiple sclerosis. In other words, they may have had an episode of numbness, tingling, double vision, and were never investigated and were never told they had multiple sclerosis. So the specificity is very poor. The other thing is, whenever you change the criteria, alter them, you may change the natural history. And that's the real question. Are we changing the actual natural history of multiple sclerosis by evolving criteria? And the answer is, and this is the Will Rogers phenomenon. Will Rogers was a comedian that lived in Los Angeles in the 1930s, and he was very famous for making the statement that when the Okies, people living in Oklahoma, moved to California, they raised the average intelligence levels in both states. And this statement is what underpins the so-called Will Rogers phenomena. In other words, if you change the definition of the disease, you change the prognosis of the disease. And this is an example. This cartoon demonstrates that. So on the left you have what we call clinically isolated syndromes. These are people presenting with single attacks. And on the right you have people with relapsing remitting multiple sclerosis. They've had 2 or more attacks. Well-defined barrier between the two. The one has only 1 attack, the other has 2 attacks. Now with the McDonald criteria you can now make the diagnosis of MS after 1 attack. So what you do is you take a group of people that have more active CIS and you make them having relapsing remitting multiple sclerosis. So you change the dividing line between these groups by moving the more active patients into relapsing remitting MS group. But these are less active than those. Maria Piersamani with Xavier Montalban's group have shown that when you change the criteria and you diagnose people with multiple sclerosis using the McDonald, the prognosis improves. Similarly, the prognosis of the CIS group improves. So we have actually changed the prognosis of multiple sclerosis by devising or evolving our criteria. And as you are aware, the McDonald criteria are very dependent on MRI. So we now have let MRI into clinical practice at the diagnostic end of the disease. And the question I would like to propose to you in the audience today is, why can't we use it in the monitoring or prognostic end of the disease? So MRI has already come through the back door. Now the other issue is MS doesn't just begin at some point in time when you have a clinical attack or an MRI, your lesion load increases or you have an active lesion. To me, MRI is a biological disease, and if you study the disease in detail, you'll realize that the risk probably starts in utero, and a whole lot of factors act in life to increase your risk. We call this the MS endophenotype. So I don't believe MS begins where our diagnostic criteria tells you it begins. It probably begins a lot before that. So if we really wanted to study this disease in detail, we should start thinking about how can we diagnose this disease earlier than when people present, and that's important if you would like to prevent multiple sclerosis with prevention strategies. So I have no problem with the next rendition of the McDonald criteria, say in 2016, coming out with a new set of diagnostic criteria where we'll be able to diagnose asymptomatic or pre-symptomatic MS. At the moment, this is referred to in the literature as radiologically isolated syndromes, and the reason for that is that people with other symptoms have scans, and if those scans show lesions that are typical of MS, we call them as having a risk. So that brings us now to disease-free status. And disease-free status, again, will be a concept that we have to define, and we'll define it by what we want to measure. So just to go through a brief review of what we consider the current dogma in the pathogenesis of the disease, we believe that multiple sclerosis, people who have the disease, have an autoimmune endophenotype, and that probably starts in utero and builds up through childhood and into adolescence. Then something happens and we get immune activation, and this involves both the so-called innate and the adaptive immune responses. For brevity, I won't go into that. And that sets up a focal inflammatory reaction somewhere in the central nervous system. And that inflammation results in oligodendrocyte toxicity and demyelination, and it may acutely transect axons and even cause loss at that stage. Associated with the focal inflammation, we get breakdown of the blood-brain barrier, and we can see that using MRI. And depending on how severe this is, we may recover, and this is so-called axonal plasticity and remyelination, or we may subject that particular pathway to delay neuroaxonal loss and gliosis that occurs downstream or months to years later. So that's the current summary. And this has clinical correlates, so the acute damage results in a clinical attack or a relapse. When you get axonal plasticity and remyelination, we get clinical recovery, and the delayed neuroaxonal loss and gliosis results in progressive or secondary progressive disease. Now we can measure this with biomarkers, so the blood-brain barrier breakdown can be measured using gadolinium-enhanced MRI, and the focal inflammatory lesions can be measured using MRI T2 and T1. T2 are much easier to measure and read than the T1. And we can also measure the delayed neuroaxonal loss by measuring the progressive brain and spinal cord atrophy that occurs in people with the progressive disease. And my favorite is we can measure it using soluble markers, for example, the release of neurofilaments, the structural proteins of axons, into the spinal fluid. And the current concept is if you can stop the inflammation, which you do with anti-inflammatory drugs, we will stop all these downstream events. Now the reason why I put question mark here is because we assume by stopping all these events that we will delay or prevent the secondary progressive phase of the disease, and I have to be honest with you, I am not confident that we've shown that yet convincingly. We may impact on this, but we have yet to show that. So these green ticks represent what we consider at present disease activity free. So you have to have no MRI disease, and that's classic T2 and GAD enhancing lesions, which is a marker of the blood-brain barrier breakdown. We have to have no clinical attacks, and we have to have no disease progression. So this is the first publication in the field. This was the results of the natalizumab versus placebo trial, and the top graph here is a representation of patients with clinical activity. So this would be relapses or disease progression, and the bottom is MRI activity. And just looking at the years 0 to 2, you'll see that the delta, the difference between placebo and natalizumab treatment was 29%. In other words, 64% of people on natalizumab were activity-free, clinical activity-free versus 35. And on MRI it was 58 versus 14. And you can see the delta, the difference between the treated and the actively treated and placebo groups is greater with MRI and clinical. And this is the backdoor MRI criticism, is that this is heavily favored in favor of the more sensitive outcome measure, MRI. This is now looking at all those parameters put together. So this is disease activity free, both MRI and clinical, and you can see that from year 0 to 2 the delta is 31%, 37% of people on natalizumab, were disease activity free versus 6%. What's interesting, if you just focus on year 2, you get a much higher delta. It's 55%. So it's 68 versus 13%. And the reason for that, I think, is related to the fact that natalizumab doesn't work immediately. It takes 2 to 3 months to start having its effect. So in other words, if you were destined to have a clinical attack or a new lesion on MRI in the next 2 to 3 months, and you start the drug now, those lesions are going to occur anyway, regardless. So a lot of the lesions that occur in the first 2 or 3 months will be captured if you use the baseline scan. So I think it's very, very important that when you start considering disease activity free, we need to probably re-baseline, do another scan after the onset of action of the drug. Now this has clinical implications, and the reason why it has clinical implications is because we really have emerging data from interferon beta therapy that not being disease activity free is better. So already in clinical practice we measure all these aspects, both relapses, progression, we measure MRI, and some of us also do biological markers. This is looking for neutralizing antibodies to interferon beta or to natalizumab. And these are highly predictive of failure of the therapy or abrogation of the activity of the drug. And this is Isabel Bosca's data from Valencia, Spain, just showing that if you have relapses whilst on interferon beta, you're much more likely to progress. So this is the hazard ratio of those having 1 or 2 or more relapses compared to no relapses. And you can see over a 5 to 6 year period, you're much more likely to progress if you have ongoing relapses on the drug. Similarly, if you have MRI activity, and this is a meta-analysis we've done with Rick, this is just looking at the T2 or the white blobs on MRI, you can see that your risk of progression is about 10 times if you have 2 or more lesions. What is interesting is if you just had 1 new T2 lesion, it wasn't significant. And that brings us up to the measurement sensitivity. And for those of you who try and count lesions, calling 1 lesion is sometimes difficult. So this highlights that if we do implement this on a widespread basis, we have to have ways of standardizing or improving the measurement sensitivity. Gait-enhancing lesions are easier to see because they stand out, and whether you have 1 or 2 or more, it still predicts failure of therapy in the future. Finally, what about progression? And progression begets progression, and this is the work from Xavier Montalban's group in Barcelona, showing that if you're on on interferon beta and you progress by at least 1 point, confirmed at 6 months, you're much more likely to progress in the future. So what we're talking about has implications for people with MS today. In other words, if we don't render them disease activity free, they're much more likely to have progressive disease in the future. This is the cladribine results. I'd just like you to focus on weeks 0 to 96. So this is comparing the year 2 with the baseline scan, and you can see if you went on to cladribine, you had about a 45% chance of being disease activity free compared to 16% on placebo. And since those 2 publications, every study now does this analysis, and this is the results of fingolimod in the Freedoms 1 study presented by Ludwig Kappos 18 months ago at the American Academy. This is the BG12 results that I presented this year at the American Academy. Now, one of the things is the companies that market MS disease-modifying therapies are trying to get us to use these drugs to look at relative efficacy. In other words, compare BG12 with fingolimod or BG12 with cladribine or natalizumab. And I think that's not possible. And the reason is, first of all, most of these studies are using the baseline scan. And if a drug takes months or 6 to 8 months to work, or another takes 2 weeks, this particular metric will disadvantage the drugs with a slower mode of action. So I think you really have to be very careful when comparing studies and drugs with each other. I don't think we're at the stage where we can do that. And this is fingolimod in the Transform study, where it was compared to interferon beta. And this is the latest. This is the KMS1, the alemtuzumab versus interferon beta 1A, which was presented at the European Neurological Society meeting earlier this year. A lot of people came up and criticized alemtuzumab, saying, well, we're expecting this drug to be the most effective drug to emerge, yet only 39% of people were disease activity free across the 2 years. And this is the problem. Alemtuzumab is an induction therapy. It's given as an infusion in year 1 and year 2, and it takes many, many months to start working. And the difference between maintenance therapy and induction therapies is not trivial. So if you are a maintenance therapy, taking it every day or weekly, and you have evidence of disease activity, that's an indication that the drug is not working properly. You're either failing therapy or you have a suboptimal response. In the case of alemtuzumab, disease activity means you need to be retreated. So there's a philosophical difference, main difference between maintenance versus induction therapy. The other thing is, now that we have a plethora of disease-modifying therapies that have emerged, it's going to be very difficult, if not impossible, to do placebo-controlled trials. So therefore we're going to have to run head-to-head studies, and if you do the power calculations using clinical outcomes of head-to-head to show superiority, the studies have to be relatively large. So one of the concepts is, can you use a composite score of disease activity free as an outcome measure in clinical trials? And the answer is sure, you can do that. And when you do the power calculations, it allows you to do much smaller trials and get the results quicker. So it does have implications for power calculations in trials. Again, the critics and the cynics would say, well, this is just using MRI as an outcome measure for disease-modifying treatment. I think we as a community need to ask the question, is that good enough? And if it is, we should push for the regulatory authorities to recognize this composite. It's going to be, otherwise we're going to have problems developing new disease-modifying therapies for MS. So the gorilla or the elephant in the room. So all this in the red box is what we don't know about. So we do know that if you switch off focal inflammation and you switch off all these pathological processes at the top half, okay, we may or may not impact on this. And the reason why I say the alemtuzumab data is that when you use alemtuzumab early on in the disease and switch off disease activity, most of the patients stop relapsing and their disabilities improve. However, if you use it in patients who have relapsing secondary progressive disease, although you switch off relapses and MRI activity, the majority of patients continue to progress. So in other words, you're not impacting on that so-called progressive phase of the disease. And I call this phase the so-called post-inflammatory neurodegeneration that occurs. And this series of MRIs illustrates that better than anything. And this were two people with MS that participated in a anti-CD4 trial, a drug that targeted a specific lymphocyte subset back in the 90s when I was doing my PhD. The patient on the left had very active disease, large numbers of enhancing lesions during the study, whereas the patient on the right only had one single enhancing lesion over the 18-month period. You need to compare the first and last of the scans just to see the difference. So in this first patient, you can see there's quite a bit of atrophy, shrinkage of the brain, but not nearly as much as the second case. And the second case had very little inflammation. So this is a visual illustration showing you that there's a disconnect between focal inflammatory events, which are, for example, relapses, and the so-called neurodegenerative component of multiple sclerosis. So we really need to think about how we define disease activity-free status in people with progressive. And this particular study, which I found very exciting, is from Jan Lick's group in Gothenburg, Sweden, where they took people with highly active relapsing multiple sclerosis, both relapsing remitting and secondary progressive, and put them on natalizumab therapy. And you can see that when they went onto the drug and you did a lumbar puncture and measured their neurofilament levels as a marker of axonal injury, nerve and axonal injury, you can see levels were very high. And when they lumbar punctured them 6 to 12 months later, most of the patients had normalized their levels to a level that was very similar to healthy controls, which is not surprising. The drug's very effective. Put them on the drug, stop them having focal inflammatory events, you reduce neuroaxonal injury, and you normalize the neurofilament levels. In the secondary progressive group, the levels did not come back to normal, which means that even though you switched off the focal inflammatory events, there was ongoing, persistent nerve loss or damage. And this again supports the observation from the alemtuzumab, mitoxantrone, and bone marrow transplantation data that if you use potent anti-inflammatories in the secondary progressive phase of the disease, you do not stop the so-called delayed neurodegeneration that's ongoing. Just to say that I'd like to thank the National MS Society. They've just given me a grant to test a neuroprotective drug in people with secondary progressive disease that are already on disease-modifying treatments, but still have elevated neurofilament levels, to see if we can impact on this delayed neurodegeneration that is ongoing. So, to conclude, or at least provide you with questions, what would disease-free status look like? Well, at present, our current definition means relapse-free, disease progression-free, and no new or enhancing lesions on MRI. And the question I'd like to pose to you, but what about the brain atrophy, the neurodegenerative component of the disease, and what about us incorporating neurofilament levels into the algorithm? I can tell you now in Sweden, you can actually order neurofilament levels as a routine, and that's been incorporated into clinical practice both in Gothenburg and at the Karolinska Institute. Should the definition be stage specific, and I personally think it should be, the reason is, how do you define disease activity free in people with progressive disease? If you stop them having relapses, stop MRI activity, but they're still progressing, can you claim that they're disease activity free? So I actually think that we should focus initially on the early relapsing phase of the disease, where it's much easier to define what we're trying to define a definition of disease activity free. We really need to consider what we do about the so-called post-inflammatory neurodegeneration. That may have nothing to do with what causes or drives multiple sclerosis. And a lot of us are beginning to realize that the best predictor of this is age. And maybe an inflamed brain, and we have some hints for this, causes accelerated or premature aging. So what drives secondary progression or primary progression may be aging. How do we find an appropriate baseline for comparison? I hope I've convinced you that we can't use time zero. We have to put patients on drugs and then re-baseline them, and that time point will vary depending on which drug you use. So for interferons, I'd imagine re-baselining will be appropriate at 3 to 6 months. For drugs like BG12 or even alemtuzumab, you may need a later re-baselining, possibly at 12 months. And I think that needs to be agent-specific. And how do we deal with the difference between maintenance and induction therapies? And I think this is something we need to educate the community about, as well as people with the disease, that if you're on a maintenance drug, taking it daily or weekly to suppress the disease activity, any activity is an indication of non-response or suboptimal response. Whereas if you're on an induction therapy, it's time to retreat. And then clearly, I hope I've made the point that we have to standardize, or at least improve on the metrics. It's very frustrating when you get one neuroradiologist reading the scan saying there's no new lesions, and when you look at them yourself, you can see 2 or 3 and just haven't been adequately documented. Finally, the dogma may be correct, but I do think we need to just step back and ask ourselves, should we challenge the dogma? And I think we personally believe that all this stuff above may be secondary to, for example, a viral infection that targets oligodendrocytes and causes death and demyelination, and the inflammatory reaction may be secondary to a virus. Therefore, by switching all this off, we leave this unchecked, and we may be in for a surprise. In other words, patients with multiple sclerosis treated aggressively, and you switch off the inflammatory response, they may come back in the future with secondary progressive disease. Now, another way of looking at this is to try and define the extreme. Maybe we should ask ourselves, what will a cure in MS look like, and work backwards. I personally find it often easier to define extremes, and maybe that's something we should define like they do in oncology. What is a cure, and then work back to a point where we are comfortable that we have a definition, or a workable definition of disease activity free. So has this concept disseminated? So prior to coming here, I put up a quick survey on our blog. You may be aware that we get about 1,800 to 2,000 hits a day, and I put up, this is the result after about 24 hours, simply asking people with MS whether or not their neurologist had discussed the concept of being disease activity free with them. And the majority, 86%, said no. So this is something that's not discussed openly with people with MS. Question 2, in the last 12 months, has your neurologist done an EDSS on you? And the question was no or not sure in 62% of people. So EDSSs are not routinely being done in clinical practice. And not surprising, it takes 20 to 40 minutes, depending on the stage of the disease, to do an EDSS, and that's just not appropriate if you've got a busy clinical practice. In the last 12 months, has your neurologist done an MRI to assess your disease activity? And yes, 52% of MSs said that they had. So in other words, people are using MRI to monitor the disease. And in the last 12 months, do you know if your MS disease activity free? And only 30% said yes. So 70% said no or not sure. So this is something that's, this concept of disease activity free status is something that has not been taken up by the wider community, and I think we're going to have an massive educational program to get this concept across. Thank you for taking the time to listen to me.